Welcome everyone to the booth talk. I'm coming to this with a lot of experience of a whole range of different MIGs. What's interesting for me about iTrack Advance is that I was using iTrack many years ago in one of its first iterations, and I'm now coming back to the technology because of the kind of greater ease of use and a sort of familiarity now with angle surgery from a whole range of different devices, but also the ease of use of the handpiece that's now available means that it's really very similar to, in terms of simplicity of use, of all those other things that we've become familiar with, but it's got a very different mode of action. So it's got a very different way of lowering pressure and a mechanism of giving us prolonged outflow facility after the device. So thank you very much. Next slide, and we'll start with some cases. So this is really just a series of 3 cases that I did, very, very brief, bare bones, clinical. Next slide, please. Clinical details of 3 cases from what was actually my first list using iTrack for over 5 years, certainly pre-COVID, and the first with the new Advance. And the first was a normal tension patient where you'd had a secondary component to their glaucoma because they'd had a series of recurrent acute anterior uveitis. They had moderate nerve damage, and they had pretty well controlled pressures on medications, but these were all patients who were having cataract surgery anyway. So my view of MIGS with the whole interventional glaucoma mindset that Ike's made, has really elaborated on and made so popular, is to, every time we're doing cataract surgery, every time we're in the eye, that's an opportunity, and then it's beholden on us to choose what we're going to use for that particular opportunity to give them long-term pressure control. So they really had quite a lot of significant damage, particularly on the OCT in that right eye. Next slide, please. And then something to show early damage shown on the field. Because we were doing cataract surgery anyway, we had an opportunity to do canaloplasty. I didn't want to do anything that was going to be significant, give them expose them to significant risk at the time of surgery. They're a relatively young patient. The opportunity to do something that would potentially lower the pressure without leaving metalwork behind in the eye and with zero risk to the corneal endothelium was the reason for choosing canaloplasty for this one, so we got this onto the list. And then they had a pressure of 10. They'd started off with 12 on medications, but at 6 months post-op, they were off all medications at 8 weeks, and they had a 6.5 visual acuity. So there were no visual complications of the canaloplasty. They had pressure lowering. It's not an RCT, it's just a single case, but it just gave an indication of the potential safety for what we were using. No, and we had another open angle glaucoma patient. Now this one had a higher pressure. They're on combined medications, couple of meds, significant cataract. We don't see many people coming in these days with sort of 636, 638 cataracts. Most of them have sought out help before then, but some are still presenting at that sort of stage in the UK, and some people are just putting off surgery. Not much to see on their visual fields, but they had significantly raised pressures. And again, we were able to do a 360-degree intubation with high volume OVD delivery in combination with their cataract. And they had, on the same medication, we haven't yet had an opportunity to trial them without meds at all. They had good visual acuity, but also they had a significantly lower intraocular pressure with their combined cataract extraction and iTrack canaloplasty. So what we've got here is no change in meds, but a very profound pressure reduction, which is clearly a win for the patient. What I can't yet tell you is whether these meds are still necessary. They may have already achieved that floor, and when we withdraw the meds in a stepwise fashion probably, then we'll be able to find out whether or not they can be med-free and attain a target pressure for that eye. Lastly, we had a patient with pigment dispersion syndrome, and they had a more advanced glaucoma. So in this one afternoon of surgery for the iTrack, we had a whole range of severities, a range of diagnoses. They had pressures that were on combined medications. They had bimatoprost and timolol, not necessarily my first choice, but as is the way of things, people don't always come to you on your first choice of medications. And then pretty severe changes on their OCT. And you can see some really pretty severe visual field loss. And again, 3/6 degrees of intubation, and again, a significant volume, viscoelastic delivery. Reasonable visual acuity, unaided visual acuity of 6.9. There was a little bit of residual astigmatism. And again, I've now switched them on to a combo med that I tend to prefer to the Ganfort combo. But at 8 weeks, they've got a much better pressure control, and they were tolerating their medication. And I'm probably likely to leave them on that because I want to, with that level of OCT change, obviously we want to get as low as we can. So this is one of those early cases. It's got nice ease of intubation, and then it's always entertaining trying to video because you get so much flash from the LED and the guidance. But one of the nice things about this is you really always know where you are. There's no risk of internal obstructions within Schlemm's canal or blockages within Schlemm's canal diverting you without you knowing it, which is what happens with some canalicular intubation procedures. And you've got a great deal of certainty about 360 degree, you've got a great deal of certainty about precision of placement of that canal and where you're delivering the OVD to. So I think it's got a lot of great opportunities. Obviously, I'm a trialist. I like trials. I'm looking forward to seeing some really robust RCT data supporting long-term pressure control within this. What's exciting is it's got a different mechanism of action from a lot of the other things that have been investigated and that we're using so far. So there's a possibility of that being combined with others. There's also the possibility of that working for people where the other mechanisms of stripping or ripping don't work, or perhaps come with too great a risk, because we know there's a much greater margin of safety for this. So thanks very much for listening to some of my first experiences. It is only first experiences, but I'm looking forward to some more. So Ike, you've done more than me. Let's hear from you.
Thanks, Gus. Well, I mean, I appreciate those cases really nicely shown. So I want to just maybe start off before my video plays, just a couple of things. So when we think about glaucoma and interventional glaucoma, the ideal scenario is to reestablish physiologic drainage, trabecular meshwork, canal, collector system, and distal outflow, episcleral veins. And when we also think about the pathology of outflow disease, we think about the pathology going from accumulation of ECM, extracellular matrix, dysregulation of MMPs, resistance in the TM, blockage of aqueous, inflammation, and continued inflammation, fibrosis, and fibrosis leads to scarring and sclerosis. So when you think about that spectrum, if we were to do a physiologic procedure on trabecular meshwork, like laser, for example, where would it likely work? Is it going to work when the meshwork is fibrotic? Or is it going to work when the meshwork is reversible? In that early phase where ECM is built up, maybe a little bit of inflammation, but not yet the fibrotic phase of outflow disease, which is different thinking than optic nerve disease. And there's some relationship between optic nerve severity and outflow severity, but not exact. So when I think about doing a mixed procedure that's physiologic, the ideal scenario would be to address the TM and the canal and go from there. When we think about the pathology of glaucoma also, we know there's 3 levels of obstruction. There's trabecular meshwork, there's canal collapse, and there's collector channel system ostia blockage and obstruction, secondarily downstream. So when you think about all this, canaloplasty, the potential for canaloplasty is to address the system at the TM and the canal and the outflow system. The viscoelastic can stretch the trabecular meshwork and open up the the pores, between the beams and ECM reduction, can open up the canal and can open up collector system. But I also would postulate that someone who has bad outflow disease, canaloplasty alone may not be enough because the TM is so badly damaged. And that's where we think about removing trabecular meshwork or stenting trabecular meshwork. So when I use canaloplasty, I think of it that way. If I have someone I think that has earlier disease, canaloplasty I think is a great procedure, and I call it rejuvenation. That's because I always want to be a cosmetic surgeon, It's like fillers and Botox. You're rejuvenating yourself from aging. Well, we're rejuvenating trabecular meshwork and canal. Now, glaucoma is not so simple. Otherwise, we would not be going into it, right? But that's the idea. Now, it's conceptual, and don't quote me, and this isn't RCT data, but it's a conceptual idea about why we think about it. And we got to prove it, both at the histological level and clinical level. So let's play the video. This is the iTrack. How many have done iTrack here? So I can just go through this. This is a tongue-shaped spatula. It helps to basically get to the TM and allow access of the catheter. You can notice it's a pretty straight cannula. with a twistable head to allow for a comfortable hand position. I recommend not going through the regular cataract main incision, but make a special incision that we use for the iTrack cannula, because we want to approach the angle somewhat parallel, allowing us to, follow the contour of the circumference of the angle. And there's a catheter being shown. Now, my assistant's holding, or my fellow hopefully is holding the, if they're awake, I don't know if they're awake all the time, holding the syringe that's twisting the viscoelastic. If you see it here. And so I'm telling them that every clock hour, I want 3 turns. I'm pretty aggressive. Each one's 3 microliters. So I do a lot of OVD. This is the most important gonial lens in the market. It's called the DVX lens. It's named after Devish Varma. He's not listening. But direct view. So I'm not tilting the microscope. I've already entered this happens so fast sometimes. You can see how things are moving. But look how nicely the catheter is following. Obviously, you don't need to use this lens to see where you are, because as Gus said, that Henny aiming light is there for you. But this is a direct view lens. I'm just showing you the catheter pass all the way around and gliding nicely. And what we're doing is we're injecting viscoelastic. If you can't see very well in the resolution here, but the canal is actually bulging. It's like a sausage kind of bulging a bit as we're injecting. It's leading the way. And sometimes you reach an obstruction, which is usually a collector system, a collector channel coming in obliquely, and we can depress on the globe if we need to. We're basically all the way around, and then on the way back, we also inject. Now, the other thing I didn't mention is I make sure the anterior chamber is well pressurized. If the AC's hypotenuse or the pressure is low, you're risking Descemet's detachment. So pressurize the eye. Having a small incision has made a big difference than having the old technique with a microforcep, where we get loss of OVD. And that's when you get Descemet's detachment. But watch for Descemet's detachment. It's not a big deal if you catch it early. And I'm just kind of playing around with things, just showing you the dilation going back and forth. But it's a fairly intuitive approach. If you've done MIG surgery, you know how to position the scope with a gonio prism, which is great. The DVX lens, we have the scope and the patient aligned straight. And the idea is that we're stretching the TM, we're expanding the canal, and we're also getting OVD into the collector system. This is another case, and you can see that the tongue is used to incise the TM. If you need to, just make the goniotomy and then pull back and get the catheter in it. I don't always get in the first time. And it's okay, though. Back up and go back again a few times if you need to get into that opening, right? But find the opening that you make. And so the prism's on. This is a prism here. And now you see the light pass. Now, look how far back, by the way, the canal is from the TM, from the limbus. This is a myopic eye, just to show you how far back it is. Look how big that blue zone is. It's gliding nicely. And you can see the blanching of the vessels. That's pretty cool. The OVD is injected, so you know that you've got some patency in the system. And whether that correlates to efficacy, I don't know, but it's nice to see that, to know that you're in the place. And we're going to pull back. So again, I'm injecting forward and backwards. We're injecting, 100 microliters of OVD. I typically like using a cohesive agent like a Helon or Helon GV. And that's basically the canaloplasty. Now, I will use a goniotomy with this, and that's not uncommon, because in my practice, I don't get a lot of early cases. So we're putting the catheter back in. I like to do, this is the left eye, I like to do an inferior goniotomy. And here I put the catheter past here to 180 degrees. And I then move the cannula toward the angle I'm trying to cut. And I'm doing an ab-interno trabeculotomy. It's already controlled. We call this walk the dog. Use the incision as the fulcrum. Stay close to the angle. And look at the light. It's still over here. So I'm not pulling back. I want to just cut across circumferentially. And I can get a good 180 degrees of cutting. I don't do more than 180. I don't necessarily think it makes a big difference for most eyes, and there's less hyphema rate. And that's kind of what we do. Quit talking about us here, guys. And that's the video. That's the videos I want to share as far as doing the procedure. It's very intuitive, and that's my thoughts, Henny and Gus.
Very nice video. You're a little bit pressed for time, but you tell us always glaucoma is only young once, right?
Yes.
And you talk about this as a rejuvenating procedure, but also you get a lot of referred patients late in the day. How do you see this procedure? When do we do it? What's the most ideal patient?
I do think the ideal patient is earlier in disease. You know, preferably someone who's not wildly out of control. That implies worse outflow dysfunction. You know, combined cataract obviously is a nice place to place it. It's obviously hard to justify going in standalone, right? I mean, early disease, I'm not going to take the risk of going in cataract formation. So I think we're still figuring that part out, honestly, right? Because there's pros and cons in that. Pseudophakic eye, I'm more willing to go in, you know. But I think the key point is that, you know, combined with cataract surgery, I tend to use this more in the earlier stage, moderate stage, maybe medication use. And then now we're talking also about combining it possibly with other procedures. But the
And perhaps doing this first, right?
yeah. And you have the ability to do a GAT with this anyways. So you can do a procedure that rejuvenates for early. If you feel the TM's probably more chronically irreversibly dysfunctional, then add a GAT to it. So you can do both or either or in that sense. Again, more data is needed. This is all kind of hypothesis. And I'm right usually, you know, 50% of the time.
50 more, right? Okay, thank you, Mel, very much, Ike. Gus, you were just uptaking the procedure anew, right? Do you have any tips and tricks for new starters on this? What are the?
I think if you've operated in the angle before, then this is a walk in the park, because the current delivery system is it feels so familiar, the positioning's familiar, and there's nothing new or difficult about the introduction, and once you're in the canal, you know you're there. So I think if you're new to angle procedures, if you're new to MIG surgery general and operating in that space, then you've got all the adjustments of either adjusting to operating down a direct gonio view or through a tilted angled microscope. But if you've done that before, then this is very straightforward. I mean, I was really very pleasantly surprised by the ease with which one could do it, the speed with which it was, you know, I was able to feel very comfortable and get used to that procedure. So I don't really see that there's any barriers to that. One of the nice things for me was that the very, it felt a very safe procedure. It felt very controlled.
You also always use a very high viscosity OVD?
Yes, I tend to.
Okay,
cohesive.
to prevent bleeding?
Well, and also I think to probably retain longer retention in those dilated channels. The mechanisms and the duration of action of those mechanisms, I think is still to really be proven. But the safety of the procedure itself, the ease of doing it is one thing. That's our discomfort. But the safety of the procedure and the lack of problems that we had with any of the patients, and speaking to Ike, who's done many more than I have, I think means that we can bring it forward and even earlier in our choice of procedures. So that's great.
Yes, it's absolutely an improvement. Thank you very much, Gus. Thank you very much,
today,
Ike. And
happy birthday to you. Happy birthday to you. I didn't know all this.
Happy birthday, dear Ike. Happy birthday
to you. 25 again. Yeah.
And thank you very much for sharing.
Glaucoma is family, and you're a family, so thank you very much.
And they've got you an iTrack for your birthday.
Oh, thank you. Great. Thank you.